Hello, my name is Vera Riglin, and I'm here to talk to you about evaluation of the right ventricle. I have no disclosures. I want to thank Dr. Roberto Lang for sharing some of the selected slides in this presentation. Let's start our discussion by reviewing the right ventricular anatomy. The right ventricle is very different from the left ventricle in that it is a complex structure that actually has a crescentic shape. Unlike the left ventricle, which is thick-walled, the right ventricle is thin-walled, and this allows it to be a very compliant chamber. It is comprised of an inlet portion, an apical portion, and an outlet portion. It is very sensitive to changes in afterload, and as a result, it can dilate and it can hypertrophy. The right ventricle is very complex in shape and has a very complex contraction pattern. This is well appreciated in the three-dimensional image on the right-hand side of your screen. The ventricle contracts by an inward motion of the free wall, like a bellows effect, and it represents minor axis shortening. The long axis shortening draws the tricuspid valve towards the apex. And this is, again, very different than the contraction pattern seen in the left ventricle. So as a result of its complex shape and its unusual contraction pattern, there's a lot of challenges with imaging the right ventricle. And particularly it's challenging with two-dimensional echo since we're only looking at one plane at a time. Images are limited by definition of the right ventricular endocardium due to heavy trabeculation, and the retrosternal position of the right ventricle can limit our abilities to obtain optimal windows. It is very operator dependent, and to accurately assess correct right ventricular volume, we must include the infundibular because it contains up to 25 to 30% of the right ventricular volume. Additionally, it is difficult to obtain the same cut in repeated studies, thus making it difficult to assess for changes in right ventricular size. And this is well demonstrated in this diagram here. You see that if we were to do a slice through the middle of the heart, as shown in number 2 here, we would get a fairly accurate assessment of the right ventricular size. However, if your imaging plane is a little bit off axis, such as in cut number 3, you see that the size of the right ventricle is drastically different. Similarly, if we were to cut it in plane number 1. Again, depending on your cut plane, the size and shape of the right ventricle on your apical views on two-dimensional imaging can be quite different, again, making measurement comparisons difficult. There's 2 sets of guidelines that I want to draw your attention to. The first was published in 2010, and it was specifically dedicated to imaging of the right heart in adults. The updated guidelines for chamber quantification published by ASE in 2015 is a comprehensive document including all of the cardiac chambers, including the right ventricle. And there are some changes between these 2 guidelines, so I am going to be referring to the most updated guidelines, which was published in 2015, the chamber quantification guidelines. So let's talk about first how to measure the right ventricle, keeping in mind some of the challenges that I outlined for you in the beginning of this talk. So the first measurement and the most common measurement that we do is in the right ventricular focused view. And a clinical image is shown on the right-hand side of your screen, as well as an associated cartoon on the left. And you see that this is not a standard apical 4-chamber view. It is tilted so that the right-sided chambers are centered in the center of the screen, and then the left ventricle is off axis, so this is not an optimal view to look at your left-sided chambers. Similarly, in a standard apical 4-chamber view where the left ventricle is more in the center of the screen, that is not an optimal view to measure the right-sided chambers. So you need to tilt the transducer so that we have this nice view of the right-sided chambers in the center of our screen. Basic measurements we're going to make as the RV diameter right above the tricuspid valve, in the middle of the RV, and then the long axis measurement. Other measurements that we can do to confirm our findings include the parasternal long axis view, where we're looking at the proximal RVOT. Similarly, we can measure the proximal RVOT in the parasternal short axis view. And then in this short axis view, we can also measure the RVOT distal aspect. So these are other places that we can measure the right ventricle. These are good to confirm that the apical 4-chamber off-axis dedicated RV focused view measurement is correct, given again some of the limitations in measuring the right ventricle, as I mentioned earlier. And in that chamber quantification guideline paper, there is a table that gives you the normal values for the right ventricular chamber size. And in general, so that you don't have to memorize every single image on here or every single number, as a general view, looking at the RV focus view, a measurement greater than 41 millimeters at the base or greater than 35 millimeters at the mid-level suggests that the right ventricle is dilated. Also interesting to note and important to note is what is the blood supply to the right ventricle. And this is why it's important to look at the right ventricle in multiple different views, because the walls supplied by the different coronary arteries differ according to the location. Oops. So if we look at the RV inflow view, the inferior portion of the right ventricle is supplied by the right coronary artery, whereas the anterior portion is supplied by the RCA acute marginal branch. And then you see here in the RV outflow tract that the acute marginal branch and the conus branch supply those areas. Similarly, in the short axis view, when we're looking at the apical 5-chamber view and the apical 4-chamber view and the RV focused view, we're really looking at the lateral wall of the right ventricle, and that is supplied by the acute marginal branch. And then notice that the moderator band is actually supplied by the left anterior descending artery. And you can remember that by its proximity to the interventricular septum, whereas the mid and apical portions of the septum are supplied by the LAD as well. And notice also that the very apex of the right ventricle is often supplied by the LAD as well. So just keep in mind the different coronary territories depending on which view you're looking at. Now let's talk a little bit about function of the right ventricle. The most common way we do it is actually by eyeballing the RV size and function, which can be helpful as a confirmatory finding, but is very subjective. So for that reason, we have several other parameters that are more quantitative, and those include the RV index of myocardial performance, TAPSE or annular plane systolic excursion, fractional area change, tissue Doppler tricuspid lateral annular systolic velocity, or the S prime of the tricuspid annulus. And then we have longitudinal strain and strain rate. And then finally, we can measure the RV ejection fraction using 3-dimensional echo. So let's look at some examples of these different quantitative parameters. So first is looking at the eyeball method. And actually, it has a fairly good correlation, about 85%, with quantitative RV ejection fraction measurements using Simpson's calculations. But it has a high inter-observer variability, about 14 plus or minus 13%, which is fairly high. So again, we can use the eyeball method as a confirmatory and giving you a general idea of what's going on, but quantitative parameters are certainly important. So now sometimes the right ventricle can be very difficult to see, as shown in this example here, because the lungs are very close to the right ventricle, and we know that air and ultrasound do not work well together. So contrast can sometimes be helpful to visualize the RV free wall, and take advantage when you use contrast to look at the left ventricle. Because the contrast persists for quite a while, you can shift your apical view into that RV focus view that brings the RV free wall into view, as shown in this example here, and gives us a better appreciation of the right ventricular function. So take advantage whenever you're giving contrast to evaluate your left ventricle. Get that extra RV focused view so that you can improve your RV assessment. Now, looking at some of the more quantitative parameters, the first one is the fractional area change. And a normal fractional area change is greater than 35%. So if you measure a fractional area change and the number comes out to be less than 35%, suspect that there is RV systolic dysfunction. And the way that you perform the fractional area change is that you measure the area of the right ventricle in diastole, and you measure the area in systole, and then you take a percentage of the two. So it's just like measuring an ejection fraction of the left ventricle, but we're doing it actually on the right, and we're using area rather than volume. And this correlates with an MRI RVEF with an R value of about 0.69, so fairly well, and has been studied in several different ways and has been noted to be related to an outcome in a number of different pathologic conditions. Now, what about the RV index of myocardial performance? This can be done either by using pulsed wave Doppler or by using tissue Doppler. And basically what we're doing is we're looking at the isovolumic contraction time plus the isovolumic relaxation time and dividing it by the total ejection time. And those parameters are calculated again either using pulse wave Doppler or using tissue Doppler. And the numbers to remember is a value greater than 0.43 by PW Doppler, or a value of 0.4 greater than 0.4 by tissue Doppler suggests the presence of RV dysfunction. Now, what about TAPSE? So the way we do TAPSE is we place an M-mode cursor at the annulus of the tricuspid valve. We turn on our M-mode recording to look at the excursion of the annulus, and then we measure from the nadir to the peak of that excursion. And a value of greater than 1.6 centimeters is considered to be normal, and anything less than that is suggestive of RV dysfunction. And these are the correlates for the degree of RV dysfunction, suggesting based on different values that are obtained. And these values correlate relatively well with RNA ejection fraction. Remember that this is dependent on correct alignment of the M-mode cursor. So look at how this image is tilted so that we try to get the best approximation of this tricuspid annulus. So there are some limitations in terms of technique. We can also do tissue Doppler of the tricuspid annulus to measure the S prime or systolic velocity as shown in this diagram here. And again, we place the pulsed wave sample volume at the tricuspid annulus, and we turn on our tissue Doppler so that we measure our S wave. We can also measure the E prime and A prime waves, but the S wave is what correlates best with measures of global RV systolic function. But remember that this is a Doppler technique, so we must keep the basal segment and the annulus of the tricuspid valve well aligned with that cursor. If you don't, you're going to underestimate the S prime velocity. And a velocity greater than 10 is considered normal. A value less than 10 centimeters per second is indicative of RV systolic dysfunction. Now, if we are using our tissue Doppler to measure the S prime, you have to make sure you're measuring the correct wave. Sometimes it can be a little bit tricky, so you have to look at the timing. So right after the QRS, you see here that you have this wave here. This is the S prime wave. This little blip beforehand is actually isovolumic contraction. So don't mistake the isovolumic contraction spike for your S wave. And then this little wave over here is isovolumic relaxation. This is your S wave here. So just make sure that you are measuring the correct waveform, because sometimes, as exemplified in this image, it can be a little bit tricky if you're not paying attention to the timing. So again, the S wave happens right after the QRS during systole. Now, we also know that a reduced septal E prime can also be a sign of RV diastolic dysfunction. So if you have a big discrepancy between your E prime waves in the medial annulus versus the lateral annulus, take a good look at your right ventricle, because you may be picking up the function of the right ventricle when you're measuring the septal E prime velocity, and that it may also be a clue that you have right ventricular dysfunction. Here's another example of how to measure TAPSE and the RVS prime. Again, for the TAPSE, you take your M-mode cursor, place it in alignment with the basal aspect of the right ventricle over the annulus, and then we look at that excursion and measure from the nadir to the peak. For the tissue Doppler, we place our sample volume right at the annulus, and here's a nice S-wave tracing for you to measure. Now, what about strain? Strain is important because both the TAPSE and the S prime can be susceptible to tethering effects. So what do I mean by tethering effects? Well, if you have a part of the right ventricle, say at the apex, that's moving normally, because remember, the apex can sometimes be supplied by the LAD. And if you have a normal left ventricle, but only your right ventricle isn't working well, that apex may be pulling the rest of the right ventricle and making it has a normal motion, but it's not thickening. But that motion towards the apex, because of the tethering of the normal apex, will result in the movement, and it may cause your TAPSE and S prime to look higher than what they really are. So the tethering effects may result in those values not accurately demonstrating to us the true right ventricular function. So strain imaging has less effective tethering and may therefore provide a more accurate assessment of right ventricular function. Now, the myocardial fibers contract from a certain precontractile length against a certain load while shortening at a certain velocity. And that's what the strain imaging is actually measuring. So it's a change in myocardial deformation. And an abnormal free wall RV strain is a value greater than negative 20%. That negative value sometimes can be really confusing. So if you're looking at an absolute value, it's less than 20%. But if you're just looking at the absolute number and you kind of forget about that little minus sign, an abnormal free wall strain is considered greater than 20%. I'll show you later that truly normal is in the very high 20s. But if we're taking standard deviations into account, in general, less than 20%, you can definitively say that there's some dysfunction of the right ventricle. Again, just to point out that TAPSE and tissue Doppler can be susceptible to tethering and may not give a true reflection of the deformation or shortening of the right ventricle, and that's where a strain may become more useful. Strain has been looked at in various different disease states and found to be quite useful. Here's a study looking at 80 patients with pulmonary arterial hypertension, and an RV free wall strain of less than 12.5 absolute in strain was associated with greater disease severity, higher BNP, higher right atrial pressure, larger RV volumes, and mortality. So not only is this value useful in looking at RV function, it actually in certain disease states has been shown to have prognostic value. Here's another table from that for the chamber quantification guidelines from 2015, looking at normal values for RV function. These are pretty much the numbers that I gave you during this presentation. And these are the numbers here, this abnormality threshold column, that are important for you to remember when you are studying for your exam. And actually looking at interpretation of your echoes in your institution. So just keep these numbers in mind. So this table outlines the challenges with some of the 2D parameters that we've talked about. In terms of TAPSE, the pros for this technique is that it's easy to do, it's easy to reproduce. On the flip side, it's load dependent, it's angle dependent. It assumes that displacement of a single segment represents the entire function of the right ventricle, which that cannot be absolutely possible. The Tay index or the RIMP is not reproducible, can be affected by complex geometry, and it's also load dependent, unreliable and irregular heart rates, can give falsely low values in the presence of an elevated right atrial pressure. 2D strain, the pros, it's angle independent, has an improved signal to noise ratio with spectral tracking, and assumes displacement of the entire RV, not just one segment, and has less effects due to tethering. However, it is also load dependent, so can be variable, particularly in states like pulmonary hypertension, although as we've seen, despite that, it does have some prognostic values in those conditions. So now let's talk a little bit about 3D imaging. These are some examples of the right ventricle and the tricuspid valve using 3D imaging. So we can measure RV ejection fractions using 3D echo as shown here, and those are found to be more accurate than 2D imaging because it includes the RV outflow tract and has better correlation with cardiac magnetic resonance. But it is dependent on high image quality. It is load dependent, just like ejection fraction on the left ventricle. It requires offline analysis and experience, and the prognostic value has not been fully established. Numbers for you to remember are shown here. So a normal ejection fraction is greater than or equal to 45%. And here are the normal volume measurements. And note that there's different measurement values for men and for women, just like there is for the left ventricle. So more numbers for you to keep in mind. So again, if we look at how does 3D echo compare to other multimodality techniques, here's a study that was done by Dr. Lang and his colleagues in 2010, comparing cardiac magnetic resonance imaging to cardiac CT to three-dimensional echo. And here's the results from his study, and you see that the cardiac CT overestimated RV volumes compared to magnetic resonance imaging, whereas 3D echo underestimated RV volumes. So just keep that in mind, that the norm, what's considered normal in terms of values for the right ventricle varies depending on which technique you're using to do your measurement. Let's just briefly talk about the right atrium so that we don't forget about that structure. Here's a diagram again from that chamber quantification document. And the right atrium can be measured by looking at linear dimensions. And there's a minor axis and a major axis of the right atrium shown in this diagram here. It's easy and there are established normal values. However, the limitations that it's only a single dimension, It assumes that the right atrium is symmetrical, which it isn't always, and can be view dependent. Now, we can also measure volumes, as shown here, and this is more representative of an actual RV size than the linear dimension, but again, because we're only doing it in one view, it assumes that the right atrium is symmetrical in shape and normal values are not fully established. We can also do 3D echo to measure the right atrium, but again, it's dependent on image quality. There's lower temporal resolution and patient cooperation is needed. Nevertheless, we do have normal values that are in, again, that chamber quantification document. And you see the normal values here, divided again between men and women. We tend to use volumes more often in our lab and keep these numbers in mind with respect to what is considered normal. So don't forget to normalize these values according to gender. Let's move on now and talk a bit about RV hemodynamics. One of the most common measurements that we make is the estimation of the RV systolic pressure. This is using the modified Bernoulli equation, where we take the peak velocity of the tricuspid regurgitant jet and square it and multiply by 4, and then add the right atrial pressure. The right atrial pressure is assessed by looking at the inferior vena cava, and we have the patient take a sniff and see how much the IVC collapses. And the key value is looking at a greater than 50% collapse in the IVC diameter, as shown in this M-mode measurement of the sniff here. We make the measurement at the end expiration. We make the measurement at end expiration just proximal to the junction of the hepatic veins, about 0.3 to 3 centimeters proximal to the ostium of the right atrium. So this is the correct place to do your measurement here. A normal IVC diameter is less than 2.1 centimeter, and a normal pressure is when that collapse is greater than 50% with a sniff. So the key numbers to remember here are 2.1 and 50%. So an IVC diameter of less than 2.1% and a collapse of greater than 50% suggests that the right atrial pressure is normal, and we average it out at 3 millimeters of mercury because normal is considered between 0 and 5 millimeters of mercury. If the IVC diameter is greater than 2.1 and it collapses less than 50% with a sniff, that suggests that the right atrial pressure is high, with an average value of 15, with a range of 10 to 20 millimeters of mercury. And if you have in between, where you have the IVC either greater than 2.1 but collapses more than 50%, or less than 22.1 centimeters and collapses greater than or more than less than 50%, whatever those in-between values are, then we assume that the right atrial pressure is in between with a value of 8. We can also use our pulmonic regurgitation CW Doppler signal to make measurements as well. So more than 60% of patients have greater than or equal to trace PR, so this value is measurable in the majority of patients. The peak PR gradient, shown here, correlates with the mean pulmonary artery pressure, whereas the end diastolic pressure gradient correlates well with the pulmonary arterial diastolic pressure. It's important to make your measurements in the correct place. So the end diastolic pressure gradient must be measured near the QRS, as shown here, not at the P wave, as shown here. And you see that you can have a fairly large difference in the measurements if you don't do it at the right place. So measure near the QRS. We can also measure pulmonary vascular resistance. Here's the equation for pulmonary vascular resistance noted here. It works well at identifying elevated pulmonary vascular resistance. However, it can be an underestimate compared to invasive measurements of pulmonary vascular resistance at very high PVRs. And it can overestimate compared to invasive measures in patients with an elevated wedge pressure. The key measurements of what you need is the peak velocity of the TR jet and the VTI of the RVOT. And this is an example of the measurements that you need. Here's the peak velocity of the TR jet, RVOT, VTI. So you can see that the measurements needed for that calculation are quite simple to obtain. So let's look at some case examples to try to put this all together. First is a 60-year-old female with multiple medical problems admitted to the MICU with sepsis. She suddenly becomes hypoxic and hypotensive, and an urgent echo is obtained. So here's your peristernal long and short axis views. You see that the right ventricle is dilated and severely hypokinetic. Same with the short axis view, and you also see flattening of the interventricular septum. We move now to our apical images. You see there, here is the RV focused view, where you see severe dilatation of both the right ventricle and the right atrium. You see that the RV free wall is severely hypokinetic at its basal and mid segments, and you have a hypercontractile apex. So these findings are consistent with the McConnell sign, which is associated with pulmonary embolism, which is what this patient turned out to have. And here you see the tricuspid regurgitation jet. Here's our IVC that is severely dilated, more than 2.1 centimeters, and is not collapsing at all. So her right atrial pressure is at least 15 millimeters of mercury. If we look at some of the quantitative parameters that we talked about before, our RV free wall strain is -7%, which is significantly reduced. Remember that -20 value. The RVS prime is also reduced at 8. Remember the cutoff there is around 10. Our RV systolic pressure is elevated at 50, and our TAPC is severely reduced at 0.9. So all measures of quantitative function of the right ventricle suggest severe dysfunction. And that the diagnosis of that patient was pulmonary embolism, and she was treated accordingly. Next example is a 60-year-old female with a history of a bicuspid valve. She underwent aortic valve replacement for severe aortic stenosis. She also has scleroderma with associated pulmonary hypertension and is being treated with sildenafil. Here's her peristernal views. Again, you see that the right ventricle is enlarged and hypokinetic, although not as severe as the last example that we saw. She also has a mild degree of septal flattening. In the apical 4-chamber view, we do appreciate that the right-sided chambers are enlargement, but our eyeball method suggests that the right ventricular function is fairly well preserved. And when we look at some of our quantitative parameters, we see that her TAPC is right at the normal limit. Fractional area change is normal at 44%. Remember, less than 35% is abnormal. And her S prime is just a tad low. Greater than 10 would be normal. But 9 is not too bad, and really kind of goes along with the other parameters that we are looking at. Everything's just quite right at the upper limit of normal. When we look at some of her hemodynamic parameters, we see that she has severe pulmonary hypertension. We also can use her PI jet to measure her PA diastolic pressure. So if we look at the TR plus the IVC, we get a PA systolic pressure of 78. By using the end diastolic pressure of the PI jet with the RA pressure, we get a PAD of 15. And then also I want to draw attention to the tracing of the RVOT. You see that there's this notching here, and this is also associated with elevated pulmonary pressures. So look for this sign in those cases. And then using the formula that I mentioned to you earlier about the pulmonary vascular resistance, we can calculate her pulmonary vascular resistance, which turns out to be 3 Woods units. So another example of a patient with scleroderma, 41-year-old female. She also has pulmonary arterial hypertension because of her scleroderma and is treated accordingly. Here's her echo, again showing right ventricle that's severely dilated and hypocontractile, severe septal flattening on our short axis view, and this is her echo before treatment. And we look at our RV focused view. You see here that the RV is severely dilated. Our eyeball method tells us that the RV free wall is not contracting well and severely hypokinetic. However, we see that, and then we see that our TAPSE measurement is mildly decreased, as is the S prime. So in these values here support that the RV is dysfunctional, and when we measure our fractional area change, that is also reduced at 20%. Well, again, we see that notching in our RVOT spectral tracing. And we can measure our TR velocity, our IVC for looking at the RA pressure. We did not have a PI jet here to measure a PAD, but based on the values that we do have, we can measure the PA systolic pressure and the pulmonary vascular resistance as shown here. So remember, for the pulmonary vascular resistance, we need the VTI of the RVOT signal and the peak velocity of our TR jet. After treatment, her echo is repeated and is shown here. As you see on the short axis view, she still has some septal flattening, although not as severe as it was before. And based on our short axis view of the RV, it looks to be somewhat smaller. When we look at our quantitative parameters, our TAPSE is now 2.3, which is well within the normal range. Our S prime velocity is now 17, which is well within the normal range. And then when we look at the signal of our RVOT, we see that that notching pattern is no longer present. So she had a very nice response to the treatment for her pulmonary hypertension. So with that in mind, there's some key points that I'd like for you to keep in mind when you're studying for your board exam. First, know your RV anatomy and the coronary distribution. Know how to perform the RV measurements and what the normal values are. Understand the methods to quantify RV function and the normal values associated with those measurements. Know how to calculate pulmonary vascular resistance. And be able to recognize echo signs of pulmonary hypertension. So with that in mind, I wish you a lot of luck during your exam, and thank you for your attention.